Yeah, so that's a very good question. It's actually an important topic. Cardiovascular disease is very common in patients with cancer and any types of malignancies. And cardiovascular disease contributes a relevant part to mortality in patients with cancer. We see that about 13% of all cancer patients have at least one cardiovascular risk factor, and 5% have cardiovascular disease. We see that the risk for mortality is increased in particular with heart failure, where the hazard ratio is about 1.8, and with prior myocardial infarction is 1.5. And then there are other risk factors like atrial fibrillation. Hyperlipidemia is less of a risk factor, but the first few that I mentioned are very relevant. And because of that, it's actually cardiology becomes a relevant part in oncology, and there's actually a change in thinking about how we should treat cardiovascular disease, even in patients with advanced cancer, while we were less aggressive in the past because it's so frequently a cause for mortality. The trend is to become more aggressive with treatment of those patients, even with ICD. So the threshold for ICD is getting lower, and also the one for mechanical life support, mechanical circulatory support. Yeah, that's it.
Okay.
One important, very much talked about topic is checkpoint inhibitor-induced myocarditis. So there we understand the mechanism already very well. So the checkpoint inhibitors, they cause a double inhibition of the immune system. So the immune system becomes very aggressive and also attacks self-tissue. So patients get myocarditis. But then there are other consequences of cancer itself. So there's a lot of research of how cancer itself can cause damage to the heart. We observe this in the clinic all the time. I had a patient who actually had renal cell carcinoma, and he had an ejection fraction of 15%. And initially the surgeons held off surgery, and we all decided it would cause more risk than potential benefit, the surgery. We were very concerned that the patient would die during surgery. On the patient's wishes, and also because there were not really better options. Ultimately, the risk was taken to do the surgery. And actually after surgery, the patient finally improved with his ejection fraction to 45%. So it doubled after removing the tumor. So there's definitely evidence that, not just from this one case, that the tumor itself can cause damage to the heart. And there's a lot of research in that area. And then, of course, side effects of treatments. We know radiation can cause coronary artery disease, pulmonary fibrosis, as a consequence, pulmonary hypertension, right heart failure. We can get constrictive pericarditis from radiation. Cachexia due to the cancer can cause heart failure. The cytokines of the tumor probably do something to the heart that's harmful. And of course, there are drugs like adriamycin that are known to have direct cardiotoxicity.
Okay.
And sorry, if I may add, often we see arrhythmias in those patients, and I think the mechanism is remodeling through radiation and toxins from chemotherapy. Yeah, so we did publish in 2017, when checkpoint inhibitor-induced myocarditis started to become a relevant topic in the literature. We did publish in an editorial for OncoTarget together with my colleague Karina Brüstle, who is now at New York Columbia University, an algorithm how we suggest patients with checkpoint inhibitor-induced treatment, checkpoint inhibitor therapy should be followed. We recommend at baseline an EKG, an echocardiogram, ideally with strain analysis, because this is more sensitive in detecting dysfunction than just getting the ejection fraction, and troponins, and then repeating this every 2 to 3 weeks. And then if you see signs that the troponins go up, then the patient needs to be evaluated for myocarditis. And one way would be an MRI. If you have a high suspicion for checkpoint inhibitor-induced myocarditis, you should do a biopsy. There's actually a case report from UCLA that was just published in ESC Heart Failure, which I also presented in my talk at ESMO, where it showed that the biopsy was more sensitive than the MRI, and the findings of myocarditis were only showing up later in the course after the biopsy was already positive. And yeah, so that's and to manage the adverse immune reactions, already in 2017, we suggested in the algorithm based on the current case reports and case series to use steroids, and that's still the main therapy. And that's in agreement with the guidelines of the American Society of Oncology and also of the American Heart Association. If a patient undergoes therapy that could be cardiotoxic, definitely they should see a cardiologist before. That's also now a clear recommendation in the new guidelines of the European Society of Cardiology. They should get a screening with echocardiogram, and again, ideally with strain analysis. And if there is any signs of cardiomyopathy, even if the ejection fraction is not decreased yet, preventatively, I would recommend to give beta blockers and ACE inhibitors, at least at a low dose, if the patient will have cardiotoxic chemotherapy, and then follow up every 3 months, and then work with the oncologists together to see if chemotherapy will have to be reduced if the ejection fraction goes down or strain shows worsening.